All right. Um, I bet most of you have heard this before. So, I did add a little nutrition science in here just because this is a grand rounds and I thought we should be a little scientific. But I wanted to share a little, some dreams with you that it takes a village and it takes a community to help us really do some of these large lifts that we need each other to figure out and explore together. So, um, what is salutogenesis? Probably my favorite word is the genesis and origins of health. And as we explore this cultural shift from pathogenesis, pathos to suffer, the genesis of suffering, uh, why don't we focus on what we all want for each other? And how can we create a science for us to recreate this healthy tree that lives within a dynamic context, a dynamic ecosystem? And what are the true determinants of health? And so we have some good science to guide us, but how do we do this here in our community, in our university, in this community, and for Wisconsin and beyond? It's really the Wisconsin idea. And I've had some just wonderful, stimulating conversations with my partners, Jennifer Edgoose, executive vice chair of our department, and Jerome Garrett even the Wisconsin idea assumes that we're projecting our science onto the community without first asking the community and understanding what they feel they need. So this science first asks and first listens and then uses our expertise in service of the best outcome. But you can't do that. You can't apply the science until you listen. And so much of this is just about sitting in mindful presence with those we serve and developing that insight. All right, where did this term come from? Aaron Antonovsky. He was an Israeli-American social scientist who studied survivors of Jewish concentration camps, particularly women. And he looked and said, how can someone stay healthy after experiencing this atrocity? How could someone do this to another human being and come out of that somewhat healthy? And he came up with this philosophy. He said, my fundamental philosophical assumption is that the river is a stream of life. And within that river, there are forks that lead to gentle streams or dangerous rapids and whirlpools. And his main question was, wherever one is in the stream, whose nature is determined by historical, social, cultural, and physical environmental condition, what shapes one's ability to swim well? What shapes one's ability to swim well? So you have to put that human within a context, within a dynamic environment, and understand the context in which they live. You can't just apply a scientific guideline to every human being. You have to listen to their story and understand the context that we all live. So we have some good science for this, that health is much more about what we do than what we take by far. And I'll say that again, health is much more about what we do than what we take by far. This is a study looking at longevity, and those who did these 5 things well had a healthy weight, healthy diet, didn't smoke, moderate alcohol, and regular physical activity. If you're a woman, you lived 14 years longer, and if you're a man, you lived 12.2 years longer. That's a pretty good medicine, 14 years of quality living. But the interesting thing was, guess how many people actually did all 5 of those things? Less than 4%. So, this is hard, but how do we support people in finding this path towards health? 14 years, that's a pretty good medicine. And we have great scientific data to support that. So I say this a lot, and no one's fired me yet, but it is true. We have a $4 trillion healthcare system that does not produce health. We have the most expensive healthcare system in the world that is harmful and not very effective, to say it in another way. So we have a system that isn't a system and certainly isn't healthy. So we should be aware of that. But culture is hard to change. When we live in a healthcare culture that pays for a lot of kids' tuition and puts food on the table for a lot of people, it's hard to change a dysfunctional system. It's like being abused as a child and then not abusing your child, right? How do you change that which we've been enculturated into is a difficult task. I'm a fan of bias. I think every human has bias, right? It's not right or wrong, it just is. But the important thing for all of us to do is pause and recognize our own biases. And if you look in the history of healthcare, we've had a couple types of bias. You know, a lot of physicians smoked. So there was this confirmation bias with an I, that we would pull out the research to support our bias. There's a lot of research out there, and you can pretty much pick the study to support what you believe in. So that's an example of confirmation bias. Conformation bias is that we conform to the norms around us. An example of that is all these nurses smoking because that's what we did at the time. We all smoked together, despite the science saying, maybe this isn't so good for us. All right, so I love that. I would argue, even if we have the most dysfunctional healthcare system in the world, we will turn around in that elevator because that's normal. That's what we do. I'm asking us to stay facing forward. I'm asking us to buck the system a little bit, to be a little rebellious, like integrative medicine was born into this need to bring both traditional and non-traditional things into healthcare delivery. And that salutogenic science requires network or system science. I love this graphic in the middle. This is all the technology, all the artificial intelligence that goes into one Facebook post. So you post something on Facebook. It might be about your favorite beverage or your political, something. Once that post goes, all these computers analyze that post, put it through this wide network, and feed you things that you already believe. And also feed you things to try and sell you stuff. And what does this do to our culture? It actually creates this narrow-mindedness. It actually tricks us into believing we already know what we need to know. And it narrows that cognitive thought, where in order to be really good at health and healing, we need cognitive diversity. We need to recognize that there's multiple ways to solve problems, and we need that cognitive diversity to really have an aha moment that helps us solve complex problems. So we have the technology, but how can we use this technology for health and healing instead of just reconfirming our biases or selling us a product? So it's using this technology in a new way. So we go away from the pathogenic. Sorry, I don't want to say go away. We still need to solve disease, right? So this is a yes and for sure. It's not an either or. This is a yes and. So we honor all the expertise we've done in pathogenesis, right? So if you have a rare diagnosis, go over here to our comprehensive cancer center. We've got really good people who can help you address that rare condition. But the culture of pathogenesis is very linear. Here, it's this XYZ model. You come in with the symptom X, we give you a diagnosis Y, we get reimbursed Z. It's very linear, and anything in nature is not linear. Anything in nature is complex. And so how do we go from take this pill to find this pattern? Find this pattern within the context of human lives. And I was honored to help our first year medical students at the University of New Mexico interview their first patient. And they all had to do it on Zoom, but I was there, and Jerry and Michael came in. Jerry had Alzheimer's disease. He was a writer, and his partner, Michael, was there for support. And Michael helped fill in some of the gaps of Jerry's memory. And the task for the medical students was take a history, find out what Jerry needs to be healthy. And so the medical students did it beautifully. They started to ask about his life, what was most important to him. And at the very end, we asked, what do you think is most important to Jerry's health? And all of them said Michael. The person who loved Jerry most was Michael. And that social support was his most important ingredient for his long-term health. He also talked about the autonomy of having a garden, and Michael helped give him the support he needed to drive and buy seeds. And one of the great things one of the medical students did was say, tell me about the inspiration for your first book. And this is reminiscent therapy. They went to the memories that were still intact. And his eyes dilated, and then he said, let me tell you about my first book. And he got all excited. And the students saw that. If you look at the research for anti-acetylcholine inhibitors, those medicines we use for Alzheimer's disease, on a 70-point scale, they work 2 points. And look at all the money and effort that goes into, and we're going to keep searching for a drug for Alzheimer's disease. We don't want to stop. But look at what matters in people's lives. It's not so much the drug, it's the process. So let's take this gets us into the scientific part of this for the fellows and the residents, other people who are interested in nutrition and science. So let's take an example of Betty. Betty has early type 2 diabetes. She also has NASH. That stands for non-alcoholic steatohepatitis, or fatty liver. Just this person is 12 times more likely to die of COVID because of the pro-inflammatory state of these conditions, make that inflammation of the lungs from the virus much more severe. So when we deal with this pandemic, which is a pandemic of metabolic dysfunction, it helps us deal with the next infectious pandemic. And this will be with us forever. So how do we improve the health of the host so we're more resilient to that next infectious process? Is it more pills, or do we have to change the process? And you can predict, I think it's the process, and it's the pill, right? This isn't anti-pill. This is recognizing the importance of the process. So let's explore a few key studies on preventing prediabetes to diabetes. This was a diabetes prevention trial, 27 centers. They compared metformin to diet and exercise to control group. Metformin worked really good at preventing prediabetes to diabetes, reduced risk by 28%. But diet and exercise, they averaged about 8 pounds of weight loss, 58% reduction. What you do is much more important than what you take. And the funny thing about this trial is that they had to stop it early because it was unethical to keep nutrition and exercise from the control group. I can just imagine, stop the press. It's unethical to keep diet and exercise from the control group, right? So that is the diabetes prevention trial. The PREDIMED trial. The PREDIMED trial took prediabetes and looked to see who went to diabetes just with nutrition, a Mediterranean diet with olive oil or with nuts versus a low-fat American Heart Association diet. They didn't follow calories. They didn't follow weight loss. They didn't follow exercise. All they did was change their nutrition. 52% reduction with the Mediterranean diet, which is a multicolored whole food plant-based diet, low in red meat, low in dairy, high in multi-grain fibers. 52% reduction just by changing the types of foods. Now, the DIRECT trial and DIADEM trial, this is after type 2 diabetes is already in place. And they put them on an aggressive, they met with a nutritionist, they put them on an aggressive liquid diet for weight loss. 86% went into remission with 15 kilograms of weight loss. So this essentially cured this condition. And then this was followed up with another study that looked at medication versus lifestyle. With medication, we have medications that can help with weight loss. Medication, the weight went down 8.7%. With lifestyle, it went down 26 pounds. Sorry, weight was 8.7 in the medication group, and weight was 26 pounds in the lifestyle group. hemoglobin A1C, which is that measurement of diabetes control, also went down more in the lifestyle group. Now let's look at the comparison of medication versus lifestyle. The lifestyle, which is a supportive program with a health coach and a nutritionist to help us really give people the information and the tools they need to do this and sustain it over time. Remission rate, 61% in the lifestyle group, 12% in the medication group. Look at the number of medications. Polypharmacy is an epidemic in our country because we rely so much on the pill and not the process. With the lifestyle, the medications went from 3 to 1 in the medication group, as you'd expect. It's the medication group. We went from 3 to 5. Percent on lipid drugs was only 26% in the lifestyle, 76% in the medication group. Blood pressure normalized in 71% in the lifestyle group. Even on a bunch of drugs, it did not normalize in the medication group. Quality of life increased in the lifestyle group, went down in the medication group. Physical activity. Which one do you want? It's not a difficult question, but it's hard. It's hard to change your lifestyle. We need to care for people in deep ways. We need to support them because it's hard, and we need policy, right? All right. This is a graph showing that the second cause of liver failure in this country is no longer infectious hepatitis. We developed good drugs to treat infectious hepatitis. But now fatty liver has become the second leading cause of liver failure in this country after alcohol. 2 excesses. One is excess of alcohol, the other is excess of sugar. So the pathophysiology of fatty liver is not eating too much fat, it's eating too much sugar. So if I don't drive the sugar into my muscle, my body makes triglycerides to pick up the sugar and transport it into fat for storage. So when I don't burn the sugar, my liver makes a bunch of triglycerides. And so that's what we see with fatty liver, high triglycerides. And if you ask any first-year medical student what's on the differential for pancreatitis, after they say desert scorpion, which is always in the differential, they should say triglycerides, because chronic elevation of triglycerides causes pancreatitis, and that eventually destroys the beta cells, which are the cells that produce insulin in the pancreas. So prolonged elevation of triglycerides, which is the cholesterol of sugar, excess sugar, leads to pancreatitis and leads to worsening diabetes. So that's why we see people with fatty liver are on a path towards diabetes and a path towards polypharmacy if we don't reverse this process through supportive lifestyle measures. Only the latest and greatest research for you all. This is a study just published in the Journal of the American College of Cardiology showing that an isolated elevated triglyceride level of 150 or greater with a normal LDL is an independent predictor of atherosclerotic plaque and heart disease, even with a normal LDL. So we are learning more and more about the risks of too much sugar in the diet. And this is the epidemic of today, right? Versus the epidemic 100 years ago was different, but this is the epidemic of today. This also just published in the New England Journal of Medicine looked at the glycemic index of meals, and the higher glycemic index, meaning the faster the sugar is absorbed into our bloodstream, is associated with 51% higher risk of cardiovascular disease in events over 9 years. So how do you reduce the glycemic index? You eat more fiber, you eat more plants, you eat better proteins like nuts with your meal. Again, weight loss is hard, or else everybody would have done it by now. But greater than 10% weight loss cures 97% of fatty liver. There's no drug approved for fatty liver. It wouldn't matter if there was, because that's not the treatment. The treatment is nutrition. The treatment is exercise. The treatment is pushing that sugar into the muscles. But this is my favorite that everybody can afford, because this is pennies a day. For a drug to be approved for diabetes, it needs to reduce hemoglobin A1C by 0.3. 1 teaspoon of soluble fiber like psyllium, which is also metamucil, in 8 to 10 ounces of water before each meal reduces hemoglobin A1C by 0.6 pennies a day. What does this also do? It not only lowers glycemic index because you have fiber that binds to the sugar and slows the absorption, flattens the curve of glycemic index. It also inhibits absorption of cholesterol. It also is a soluble fiber, so it fills up your stomach with water and makes you feel full. So on average, 6 pounds of weight loss after doing this for 6 months. So it also helps with weight loss. And everybody can afford this. This is literally pennies a day. So it's my favorite therapy for people who have no health insurance at all and can't afford pills. This works pretty damn well. All right. So what about the process? My friend and colleague Bruce Barrett led some wonderful research that allowed me to explore the clinician effect. I'm not going to repeat that to you, but I wanted to share this slide, particularly with the interest and expertise, particularly our department's doing with Randy Brown and his colleagues, doing a lot of cool research on psychedelics and major depression and others. And there's always that question, set and setting. This is a study in McGill University up in Canada of college students where they created a expectation of stimulating creativity with a medicinal mushroom. So that was the intent. And in the group, they planted subjects to create that expectation. They said, hey, I heard this is a great trip. I got really creative after I took this pill. And they wanted to see what kind of spiritual out-of-body psychedelic experience they might have. And they created the ceremony. They put these posters on the wall, pictures of monkeys, mood lighting, and then they gave everybody the medicinal mushroom in a magic pink pill, but it was really placebo. And they wanted to see who would have a spiritual experience of this cohort. And 65% had a spiritual experience, who saw the monkey come alive or the pictures change on the wall. Many had that you hear a lot with psychedelic research, that connection to unconditional love. Just with the setting, just with the process. And I love this research because it shows how important our intentions are, how important that mindfulness class is, that group therapy, those things that we can do together for each other can have tremendous physical responses. So I'm curious to explore this more with you of how we might reproduce this. And, this is a lot of work that you've all done that I really enjoyed being a part of, that VA work where we start to ask different questions. What do you want your health for? You've heard all the mantras, instead of what's wrong with you, what's right with you, and how do we reproduce that? And how do we let what's important to you drive our science and our expertise in service of your best outcome? And I'm not going to tell you this story about Mount Kilimanjaro because I think I've told you all this before, and Adam, Greta, and everybody's told this a number of times. It's a great story of how we really explore what's important to the individual. So what matters and why? And when I ask myself, why don't I want to exercise, eat better? I want to be there for my grandkids, or, I really want to do this health and healing oriented work. It's those things that empowers, motivates us towards behavior change, which is the main determinant of health that's sustainable towards healthy outcomes. Versus if we just monitor hemoglobin A1C in isolation, that's an isolated domino. It really has no effect. And the top is a hell of a lot more fun. And actually, I researched this quote at the bottom for the Compassionate Connection book that we did. And we couldn't find who was the author anywhere. It's not T.S. Eliot, but I love it. The definition of a hell is a place where nothing connects with nothing. I think that's so true. All right. you've seen this before. How do we start at the center through that mindful presence and awareness? We ask the patient where they need to start of these core 8 areas that every human being needs to be healthy. And then based on their response, we create the team. So through this question, we create the interprofessional team that helps influence and support those healthy outcomes. And the first thing I did when I got back on Epic was to see if this still worked. This is what I'm biased. I thought this was the most important thing I did in my 16 years of being here. The first time was create with our Epic colleagues, and we had a patient committee to support this, where we put the patient's goal into the problem list, and it automatically floats to the top so everybody can see what's important to the patient. And we did this 12 years ago, and people just don't use it. Why don't they use it? Because we haven't changed the culture, because we've created so much normality out of dysfunction. And, you know, just this morning, I had a meeting with a faculty member about the high degrees of burnout. Why is there high degrees of burnout? Because we're caught in the minutia. We're caught in the clutter. And we really need to practice mindfulness to drop into what matters most and shift the culture. But it scares people to change, right? People don't resist change as much as they resist being changed. People love change, particularly in academia, but ask someone to change, much more difficult. So there's some research behind this. If people have a high purpose where they're really focusing on what they want their health for, their risk of death goes down almost 2.5 times versus those who have a low purpose in life. And this is really diseases of despair. And we have a lot of this in Wisconsin, diseases of despair. That leads to a lot of substance abuse. So this is really an important thing that will have a domino effect on many different areas. And I bet you've seen some of this, of some of the research that's coming out of the VA work. Look at the pharmaceutical costs for those who were involved in the whole health model versus those clinics that were not involved in the whole health model. So in the blue is involvement in the whole health model, where they ask these questions. And in the orange is those who continued on the pill for every ill model. And then look at opioid prescribing. It's hard to get people off opioids. And I would argue that opioids are inauthentic glimpses of bliss, right? Inauthentic. It numbs our reality long enough for us to have a sense of peace, and then it wears off. It's inauthentic. So I think this question, through changing the conversation through this VA work, was really connecting people to authentic bliss, right? That's the shift. Where how do we get away from the pill giving us temporary, inauthentic glimpses of bliss to real, authentic bliss? And that's hard. And it takes all of us to help figure this out. But look at those reductions, almost 35% reduction in opioid utilization for those veterans. And I didn't include the slide here, but their retention rates for those clinicians is like 95%. Unbelievable higher retention rates in those who were involved in the whole health model versus those who were not. So if you want to change a culture, change what you pay for. And this is happening. I'm so excited about this. Value-based payment models. The old model, fee for service, which is, you get paid for how much disease you see, is fragmented, reactive, and disease-centric. Part of the reason of coming back to Wisconsin is New Mexico is focused 100% on fee-for-service, and it was really hard to create innovative change in a healthcare system that still is back in the fee-for-service model. But these new payment models, these value-based payment models, are asking us to get better at the salutogenic science that requires a coordinated interprofessional team that's proactive and health-centric. And now in the future, it'll take a while, but we're going to start to get paid for keeping people out of the hospital and in their homes and aging in place and supporting them through You know, the interprofessional salutogenic team might be a best friend, a pet, a counselor, a nutritionist. You know, that person defines the team that they feel they need most for their longevity. So a couple medical disruptors. I love medical disruptors because they've been brave enough to go against the traditional culture of healthcare. Iora Health, they're up in the Northwest. They're in a completely capitated model, and they have 4 health coaches to every 1 physician. So the physician creates the health plan, but then they have 4 health coaches to support the human being in succeeding and changing their behaviors. In the highest risk population, their admission rates went down 28 to 41%. Their ER visits went down 30 to 35%. I've already been in contact with Mark Selman, the new president of Quartz Insurance, and they're excited to work with us in doing a similar process for those most at-risk patients within the Quartz healthcare system. This was a favorite of mine from Kaiser Permanente. This is a process that was instigated at Kaiser, where all they did was include a 10 or 12, I think it's 12-item adverse childhood event questionnaire. So ACEs stands for adverse childhood events. And if someone answered yes to any one of those adverse childhood events, the only intervention was compassionate inquiry. The clinician would say, hey, I see that you had this adverse childhood event. I'm sorry to hear about that. That must have been difficult for you. How can I help you through that? That was it. That was the only intervention. Reduced all medical visits by 30% for those who answered yes to one of those adverse childhood events. Look at the value of that. All right, so how do we create a health trap? In the past, we've had a disease trap. And the disease trap means I get paid more if I see more disease. We used to pay firefighters for how many fires they put out. We don't do that anymore because it's stupid. Because even good people want more fires, but we don't want that for our community. We still have a health culture that pays mainly for disease. So we're shifting that, and we're going to be leaders in that. And when you look at the main determinants of health, of how to create a health trap, you realize that you need health equity for every human being. You need that social intelligence. You need to start asking, can this person even afford to get to the doctor? Can this person even afford healthy food? When it's cheaper to buy the Happy Meal at McDonald's versus broccoli, that's a social problem. And that's why we need political intelligence. No, this is not an oxymoron. My favorite definition of politics is poly, many, ticks, blood-sucking insects. But that's not very nice. We really need smart politicians, right? We really need smart politicians because they create the policy that helps us really address the main determinant of health, which is social constructs. So that's the first step of that trap. The second one is that we have to use artificial intelligence to augment human intelligence through big data to protect humans to do more human things. And this is not going to go away. It's going to get stronger. It's going to get better. But instead of Epic being a money extraction device, which it has been over the past 15 years, we need Epic to work for us to protect our time to do more authentic intelligence, that human to human thing that only humans can do, that a computer will never be able to do, because we can see complex humans within complex patterns within the context of their life. And frankly, that's just the right thing to do. That's the moral intelligence. Don Berwick wrote about this. If you want to see it, it's in JAMA. It's called Moral Intelligence in Healthcare. And he says, when communities are broke, the healers are called to mend it. And that's us. That's you, that's me, that's all of us. That's the right thing to do. All right, so Henry David Thoreau said, it's not what you look at that matters, it's what you see. And I think that's so true. So how do we see a different healthcare system? How do we see one that complements the success we've had in pathogenic science with one that defines salutogenic science, so we can get better at achieving healthier communities, healthier people, and a healthier planet that we all live on? And I'd like to dedicate this talk. Oh, there she is. That's my mom. She passed away this last weekend, and I love this picture of her. Her name is Peggy. And when I see her in the wind, it reminds me of my favorite definition of spirituality. Spirituality is like the wind. You can't see it, but you can feel its effects. And, you know, when I talk about what I want my health for, you know, she played a big part in that. And she supported me. She loved me unconditionally. And I think she did that so I could pass it on for others, to help others do this work that we all feel so called to in our heart. So that's Peggy, and we're going to honor her this Saturday in Iowa City. All right, this is an ecosystem, right? This is my summary slide. This is an ecosystem, and traditionally in our medical culture, we give most attention to those who are focused on the narrow aspects of health, like an organ system or an expert in a disease process, which is really important. And but it doesn't really recognize the whole ecosystem. And what we want to be leaders in is that salutogenesis. And in order to be a leader in health and healing, you have to see the forest through the trees. You have to see the context of this, how this bird, this tree, this lake, this mountain interacts with an environment, and how each are independent on each other. And when you really look at the science of health and healing, we are not individuals. There is no ego, right? In the true authentic aspect of this interconnectedness of all human things. When you suffer, I suffer. And when I practice compassion, it doesn't mean I need to fix you. That's empathy fatigue, right? That burns me out. Compassion means we're in this together. And when I help you, I help myself, because there's this two-way causality, this interconnectedness of all things. And I would argue, if you understand how nature works, that this slide might give you the misinterpretation that salutogenesis is just as narrow. It's an inch wide and a mile wide and an inch thick. But I would argue that it's both. That when you see the context of human lives, it allows you to go much, much deeper, and allows us to get much more effective in being experts in health and healing. So when I was applying for the job here, I created this little graphic that, you know, how can we use all the expertise that we have, not only in our own department, but across all of the University of Wisconsin, to really work well together towards a collaboration of salutogenic science. It really honors humans, communities, and the planet that we all live on. And I added this little arrow because the main argument in this, and this is feeding into our discussion that I'd like to have here, is this is too broad. How can you sharpen the arrow to really understand how we can create salutogenic science within some of the expertise that we already have? So I'd love to learn from you, because you can't just talk about salutogenic. It's much too broad. We need some strategies within that help us invest our collective energy and our collective expertise towards a healthier, more beautiful, more joyful, more resilient outcome.